Hello, everybody. Today we will talk about the altered mental status condition, and we will start with our latest example from the ER. A 17-year-old male presents to our ER due to acute agitation and behavioral changes. On examination, a thin young male appears to be agitated and confused. He is febrile and non cooperative. He is nonverbal but grunting, and the family reports that earlier this morning the patient was his normal self, and that the patient has no previous medical history apart from upper respiratory tract infection that started 3 days ago, that was diagnosed and treated by an outside physician. He exhibits normal cognitive function, and the patient is then sedated with diazepam. Labs were sent, showed a white blood cell count of 17,000 cells per ml, and cardiopulmonary examination, chest x-ray, and general urinary exam were normal. uh, and his CMP showed a glucose of 219 milligram per deciliter. His pH was normal. His electrolyte were all within normal range. A differential diagnosis was established, including but not limited to acute substance abuse intoxication. Two was the acute viral meningitis slash encephalitis, and three we put space occupying lesions in the brain. And the patient was referred to a neurology service in the teaching hospital. A CT scan of the brain was normal, removing our third differential diagnoses. The physical and neurological examination, whether inside our hospital or with a neurology service, disclosed no focal neurological deficits. Pupils were mid dilated, the eyes were in REM movement, and so a provisional diagnosis of uh, viral encephalitis was made. A CSF was scheduled to be done 2 days later, 1 day later. I'm sorry, 2 days later, and the patient is being currently followed up in the teaching hospital. Altered mental status. Uh, the definition of mental status is the conscious and cognitive aspects of a person. Uh, it means that this person is conscious, he is conscious, or he's stuporous, he's oriented or confused, and can they perform basic or advanced cognitive functions such as memory, math, logic, and abstract understanding. Now, in order to establish a diagnosis of a decline or a change in uh, cognition or mentation, first we have to know what is the patient deviating from. So, what is his baseline? And a baseline means that what is the normal for this patient that what we see is considered abnormal. So, A, some examples for that. So if you have a deaf patient or a mute patient, and then you are writing his Glasgow Coma scale and you put on verbal 2, so his Glasgow Coma scale is 6, 4, 10, that's, and then you put 1 or 2, so he's either 10, 11, maybe 12 too, okay? And would you consider this patient to be having a decline in his mental status? Of course not, because that is baseline. Now, again, if you have a patient who have, let's say, a mild functional mental retardation, so his IQ falls between 50 and 70 IQ points, he is unable to understand complex mathematical equations or unable to do math at all, but he can dress himself, eat, goes to the shower, and when this patient comes febrile in the ER, then would you describe this patient as having a decline in his mental status? And the most common example is of an elderly patient in his 70s or 80s, and people at this age would have a decline in their cognitive function, and they should be followed up by their primary healthcare provider to assess what is their baseline. Now, of course, we don't have that in our system, so we have to rely on the history provided. So People in this geriatric age group, they would tend to forget names, places. Uh, they would confuse certain stuff. They might get acute confusion just for being in a different setting or being in pain and fever. So it is very wise to understand how much this person actually does in his normal life, and with uh, his present condition present a strike or an obvious change from his normal self. Moving to the assessment for the altered mental status, a detailed assessment of the following aspects is critical in establishing the diagnosis and severity. The first two are the most important, and these kind of the heart of the job you do in the ER, which is the level of consciousness and orientation. What we mean by the level of consciousness is that human beings tend to pass into a three stages, 3 to 4 stages during the day. They are awake, they are sleepy, slash drowsy, they are asleep, and then they are awake. And so people normally go through the 3 stages. And if the patient is excessively drowsy or he's in deep sleep and he needs to be awoken up by stimulus, then that would be uh, abnormal for a human adult. And so we would note that in our charts as the patient being stuporous, which means we have to he have to be stimulated in order to stay awake, or the patient is just conscious, uh, alert, or he is drowsy, so he looks like he's always going to go to bed, he's answering slowly, and etc. The other important aspect, which of course is only required with the patient, is in the from the conscious to stuporous situation. If he's comatose, then you would not be able to assess his orientation. And orientation means the knowledge of oneself into his time, place, and his immediate or like the person in his life, and he would know and identify them and what kind of situation he's in. The other aspects are important if the first two prove to be inconclusive, which means, and you would automatically do them. So let's say one of our last patients last month had was conscious. She was conscious, but she was kind of sluggish in answering the questions. She was fully oriented. She knew where she was and who was with her and what time of day she was in, but uh, her mood was detached. She had a flat effect. Her thought process was sluggish. She was slow to answer. Um, she did not have a full insight about her situation. And another unrelated patient, she had everything about her normal except for her long-term memory. She did not know which year she was in. She now and then missed the month of the year or the current prime minister and major events uh, that took place in the recent times. And so these kind of indicators that the patient is not his full normal self. And the easiest way to assess that is just to ask his most immediate relative, the people who live with him, does he look like his usual self? And they would say like, no, he feels different. And they might not know what different about him, but they would know that he feels different. And it's a major indicator of the patient well-being. Immediate actions in the ER. First and foremost, never neglect, never omit the ABCs, because hypoxia, hypotension, fever, and hypoglycemia are some of the most common causes of acute altermentation. And so, the patient should be checked vitally, his airway should be patent, and his breathing is normal and not obstructed, altered, or affected by any means. If the patient is febrile, then an antibiotic or wet blanket towel should be provided. Most importantly, if you see the patient is vital and unstable, he is hypoxic, administer O2. If he is hypotensive, then give volume expander fluids such as normal saline or Ringer lactate. Now, the second step, which is very important and usually gets neglected, is recording the Glasgow Coma Scale at the time of a presentation, and that's like before any immediate action that takes place. Uh, and I might get asked like which takes precedence, recording the GCS or the life-saving action. Now we should work in a team, and we should have enough hands-on to do both of these actions simultaneously. And to be honest, you can just memorize the Glasgow of the patient, look at your watch, and then do your immediate actions, and then go back and write them down. And the importance and why I stress this point is that we need to see how much effect had took place due to that specific action. So a patient might go from a Glasgow Coma scale of 4 to 7 uh, just by normal saline, and then when the advanced team like the internal medicine residents or the specialist comes by and assess the patient, and the patient is at Glasgow Coma scale 9 or 10, and then he might think that this patient is not improving, the patient is presenting with urological problems, when in fact that the patient was hypotensive for too long, and normal saline effectively raised the Glasgow Coma scale for 6 by 6 or 7 points, and that further management in this same aspect would uh, may help the patient regain full cognitive recovery. Now, as a reminder, this is the Glasgow Coma Scale. We start with the eye opening. Spontaneous eye opening is 4, eye opening to speech is 3, to pain is 2, and no response is 1. The verbal response oriented to time, person, place is 5, confusion is 4, inappropriate words is 3, sounds is 2, and no response is 1. The motor is 6 for obey's command, localization of pain is 5, withdrawal from pain is 4, abnormal flexion is 3, and abnormal extension is 2, and no response is 1. Now, a detailed history should always be taken from patients or their relatives with altered mentation. First, we start with the present history and the duration and onset and any fluctuation in the cognition in the condition, and cognition, of course, because we're talking about cognitive changes. So, what are the aspects that I would look in this condition? One is the decline was sudden or gradual. So the patient is just walking around, he's hopping around, and then bam, he's not talking, he's confused, he is having weaknesses in his right arm. Or does the patient has been exhibiting these signs for a week or so? So maybe they noticed like 5 days ago that he tied his tie in the wrong way. He forgot his watch, which he never does, and then it progressed for him to forget putting on his socks before his shoes, and it goes on like this. So, what is the rate of the decline? What is the speed of the decline? And this is very important in establishing our differential diagnosis. So, I would not suspect a patient with a stroke to have a gradual decline for weeks or days, but a sudden decline would go more with more of an anatomical cause, like a stroke, a brain tumor, a hemorrhage, and etc. Also, a patient with acute encephalitis would have a more prolonged uh, history than a patient with uh, acute meningitis. The patient with acute meningitis does not necessarily present with cognitive dysfunction, while the patient with uh, encephalitis almost always does. And he might have just personality changes. He might be angry for 3 to 4 days before losing the ability to speech, and so forth. So, the onset, duration, are very important. Fluctuation is an amazing indicator tool. It's especially helpful in patients with hepatic encephalopathy because it's one of the diagnostic cornerstone of hepatic encephalopathy is a fluctuation in cognition. So the patient one day he's bright and shine, he's remembering everything, and one other day he is forgetting stuff. It also goes for other causes like drug ingestion and substance abuse. It follows a fluctuating pattern. An increase in the dosage of certain drugs might indicate that. So always put in mind the duration and onset plus fluctuation. Two is what we already talked about, the baseline cognitive and neurological status. You cannot assess the decline without knowing the baseline. Three is drug history, as we included. Our differential diagnosis include is the drug history, whether it was a prescribed or an illicit drug, and all the drugs should be mentioned. Levothyroxine is very important. A change in thyroxine level almost always causes changes in cognitive function, whether this patient has induced hypothyroidism or hyperthyroidism. Uh, Certain drugs might not look like a culprit, but they are, and they are very common, like antihistamines, such as cenerizine, histidine, the known brand of alarmine. Benzodiazepines also causes forgetfulness. Uh, Antipsychotics, anti-epileptics, uh, are all culprits, but all drugs should be mentioned, including antibiotics, because they alter the metabolism of other psychoactive drugs, other neurological drugs, or cause damage to liver and kidneys, which in their uh, uh, own way will cause a cognitive neurological changes. Past medical history, including chronic diseases and similar previous episodes. This goes without saying. Check for hypertension, DM, diabetes, any similar condition happened in the past, epilepsy, heart disease. Every aspect, every piece of knowledge can be brought together to solve this puzzle. And a family history is also very important. So you might not think about it, but the patient could be carrying Huntington disease, autosomal dominant, and this condition happened to his father or grandfather, and now he's exhibiting the same neurological decline. Patient living condition, social status, and environmental condition is a very important and often neglected part of our history taking, because some of the causes of this cognitive decline might be nutritional deficiency. The patient is exposed to hypothermia or hyperthermia in home. He's dehydrated. He is being kept in a dark room or being abused at home, which causes changes in his psychological and or neurological condition. Is the patient a smoker? Is he an alcoholic? Which can cause a long-term damage to the cognitive function, evident by the Wernicke-Korsakoff syndrome. A thorough physical and neurological examination. And this is a very important and informative part of our assessment. And I have put just a bulletin, so I'm going to explain each part, um, and why is that important in our assessment. An eye exam should include extraocular and intraocular muscles, plus optic disc if you have a retinoscope, if that's feasible. Now, why did I write extraocular and intraocular muscles? Because that's a neat and kind of small way to write down examination of the uh, reactivity of the pupils. Are they symmetrical? Are they reactive to light? The normal position of the pupils. Is it mid dilated? Dilated? Is it constricted? What does that help us? That help us immensely in assessing intracranial lesions, plus psychomotor affective drugs in cases of withdrawal or abuse of either amphetamines or opioids, and syphilis, and many other cases. So, an assessment of intraocular muscles is very important, as well as extraocular muscles, and we assess extraocular muscles by moving our finger and telling the patient to follow up our finger, moving upward, downward, right side, and then the left side, and to see if the patient exhibit any diplopia, any sluggishness, any nystagmus, uh, if the patient develops any squints, and that might tell you if the patient's having like an abducent nerve palsy, if he's having um, a lag related to a thyrotoxicosis, of the patient is having uh, a full-blown cranial nerve 3 palsy, and so it goes. Eye examination is very important. Meningeal signs and cerebellar signs should be assessed to exclude cerebellar or meningeal uh, pathologies. Meningeal signs, um, they decrease in sensitivity and specificity as we go down. So the neck stiffness is very important, but keep in mind that elderly patients usually have osteoarthritis, which would cause uh, neck stiffness. So, as a tip, check if the patient can move his neck sideways. If he can't, then he probably would not be able to tuck his chin to his chest. Obrodzinski and Koenig sign can also be done, but they are less sensitive and specific than the neck stiffness. Cerebellar signs should also be checked to exclude any pathologies, including the cerebellum, which includes nose to finger repetitive movement, the dysdiadokinesia and chin to heel movement, and then the pulling the patient arm and asking him to pull it toward his face and check for his ability to stop it, and that would solve the dysmetria and cerebellar function. Power sensation and reflexes, three important aspects. So a tendon hammer can be very useful in the ER. If not, you can use your stethoscope with varying degrees of success, and we check the reflexes of the bicipital, the radial, the knee reflex, and the ankle reflex, plus the Babinski reflexes. Uh, you might go as far as checking the abdominal reflex and cremasteric reflex. There is the wink reflex, but it's kind of overshoot, and we would not do that unless we have uh, a specific suspicion around these nerve roots, which includes for the cremasteric the S2, and for the anal wink the S4, and for the abdominal, I guess it's the L2, L3. I'm sorry, it's the T12, L1. And after that, you have to check for power. So ask the patient to press your fingers bilaterally. Ask the patient to elevate their knees against resistance, and check for symmetrical power on that aspect. Also, you can ask the patient to press his soles with a plantar flexion to assess the sciatic nerve roots, including S1 and S2. And after that, you can assess for sensation, and we will suffice ourselves in the ER with a simple tactile stimulation to assess the presence of pain touch receptors. After doing the neurological assessment, it is very helpful to do the full physical exam, which includes looking at the patient, doing a full head and neck exam, looking at the eyebrows, looking at the head, looking for any trauma, bleeding, abnormality, hyphema, uh, poor dentation, dehydration, pallor, neck swelling, uh, enlarged lymph nodes, um, enlarged thyroid, spider nevi in the chest, abnormal nipples, capotomidosa, heart murmurs, chest examination of the arm for tremor, clubbing, jaundice, pallor, lymph nodes in the forearm, you can name it, examination of the pulse, all of it is informative as a piece of our assessment. You also check for DVT and any muscle wasting, weakness, and etc. After doing our detailed history physical exam and we are off the ABCs, what kind of workup do we need for this patient? So a basic workup, and I repeat, this is the basic workup that should be done for every patient with an altered mentation. Should include a complete blood count looking for anemia, elevated blood cell counts, changes in platelet related to maybe TTP, and it goes on, maybe a low MCV due to a lead poisoning which causes neurological symptoms. So it's very important to do CBC, CMP, which includes renal function, liver function, and electrolytes is very important. Electrolyte changes are one of the most common causes, or like one of the most common representation for electrolyte changes is mental status changes, liver cirrhosis, uremia due to chronic kidney disease are all causes of altered mentation. A blood gas analysis should be drawn. pH level should be assessed. Acidosis, alkalosis are a known cause of altered mental status. Hypo and hyperthyroidism are also a common cause of altered mentation, and TSH should be ordered. EKG should be done looking for atrial fibrillation, hypotension due to acute MI, a heart block, or etc. Chest X-ray should be done to exclude any malignancies or a chest disease, pneumonia that can cause electrolyte disturbances or a neurological sequelae. And CT brain, of course, imaging of the brain is to be determined. Other labs that I did not mention include B12 level for in-risk patient, elderly, and vegans, B12, B6, especially if the patient exhibit a subacute demyelination of the spinal cord. Now, for our differential diagnosis, we have already went through most of our differential diagnosis because of the assessment we do. So going back for the list, we have toxins, which can include prescription drugs like anticholinergics, narcotics, benzodiazepines, drugs of abuse like alcohol intoxication, alcohol withdrawal, opioids, ecstasy, LSD, and it goes on, ketamine, cocaine, bath salts, marijuana. Poisons like inhalants, carbon monoxide, ethylene glycol, pesticides, metabolic conditions like electrolyte disturbances, hypoglycemia, hyperglycemia, hyponatremia, hypercalcemia, hypocalcemia, and hypomagnesemia. Hypothermia and hyperthermia, pulmonary failure like hypoxemia and hypercarbia, liver failure like hepatic encephalopathy, renal failure like uremia, cardiac failure, vitamin deficiencies, B12, thiamine, folate, and niacin, dehydration, malnutrition, anemia, infections, whether these were systemic infections, UTI, pneumonia, skin, soft tissue. And yeah, I was meaning to talk about that. So with the physical examination, it is also important to look for pressure ulcers, for bed sores. These might be a source of infection, and sepsis, which leads to uh, altered mental status. CNS infection, including meningitis, encephalitis, and brain abscesses. Uh, this is brain abscess. The plural is brain abscesses. Endocrine conditions like hyperthyroidism, hypothyroidism, hyperparathyroidism, which of course causes hypercalcemia. Adrenal insufficiency is also a very important cause of cognitive changes, as well as uh, hypotension. Cerebrovascular disorders like global hypoperfusion states, hypertensive encephalopathy, focal ischemic strokes, hemorrhages, especially non-dominant parietal and thalamic lesions, autoimmune disorders such as CNS vasculitis, cerebral lupus, neurological paraneoplastic and autoimmune encephalitis, seizure-related disorders such as non-convulsive status epilepticus and intermittent seizures with prolonged post-ictal states, neoplastic disorders, diffuse metastasis to the brain, gliomatosis cerebri, carcinomatosis meningitis, CNS lymphoma, and hospitalization also is a cause of delirium. And with that, we are done with our lecture on acute alteration of mental status.